Welcome and thank you all for joining us to our November 1st session of the Virtual Learning Collaborative Updates to Acute and Chronic Hepatitis B Case Definition, made possible in partnership with the CDC Division of Viral Hepatitis. So my name is Zakia Grubbs, and I'm a manager on the hepatitis team here at NASDAD. And joining us today are presenters Simone Richardson, program analyst, Meredith Cohn, Director of Scientific and Surveillance Consensus Development, both with the Council of State and Territorial Epidemiologists, or CSTE, Jenny Grilly, Epidemiologist Supervisor with the Minnesota Department of Health, and our moderator, Alan May, Hepatitis C Epidemiologist with the Arkansas Department of Health. For today's presentation, we will begin with presentations from Simone, Meredith, and Jenny, followed by a moderated discussion led by Alan. So feel free to use the chat to introduce yourselves, your jurisdictions, and if you have any questions. So with that, I will turn it over. I'll turn it over to our CSTE colleagues. Thank you.
Thanks, Zakia. All right, and thanks, Meredith. So good afternoon, all. Thank you so much for inviting us to speak on this month's VLC call. Again, my name is Simone Richardson, and I'm the CST staff lead for our viral hepatitis subcommittee. I do recognize a lot of names on this call, so many of you may already know that the CSTE viral hepatitis subcommittee holds bi-monthly calls to discuss current issues and overarching topics related to viral hepatitis surveillance, such as best practices and lessons learned across jurisdictions, policy around viral hepatitis surveillance, and analyzing viral hepatitis data. So a function of CSTE and the subcommittee that people may be less familiar with is that we also review and develop national position statements on viral hepatitis, as well as other public health areas, including standardized surveillance case definitions. And to expand a little more on position statements, I will go ahead and pass it over to Meredith to dive a little deeper.
Thank you so much, Simone. It's wonderful to be with you today, all of you. I'm going to take us 70 years back in time for one slide so that this group can understand why CSTE is engaged in developing position statements and developing standardized surveillance case definitions, one of which you will, of course, be further discussing later today. So 70-ish years ago was when CSTE was first founded back in 1951. That was when the very first convening of state and territorial epidemiologists, or our council, was held. The then CDC Epi director requested this convening because not only did Dr. Langmuir recognize the importance of state input and decision-making, given the federated nature of our public health system, but he also recognized that CDC really needed the states and territories to come together and agree upon which diseases and conditions were of such public health importance at that time that the federal government needed to be aware of them for national public health action. The outcome of this first convening back in 1951 was the first list of nationally notifiable conditions. Between the 50s and the 90s, the council continued to meet annually to maintain that list of diseases and conditions. But in the 90s, when the CSTE national office opened with 2 staff, we are now up to 100. But back in 1992, the council expanded this function to not only maintain the list of diseases and conditions, but also then to standardize the definitions of cases for surveillance of those diseases and conditions. Further, in the 90s is when that function was expanded again to include standardized surveillance case definitions, not just for notifiable conditions, but also for reportable conditions that were reportable to the state level. So today, CSTE is multifaceted. We are a professional association for applied public health epidemiologists and those working in related public health areas. We currently have over 3,300 individual members as of a couple of days ago, representing all US states and DC, most territories and many localities, in addition to members working at the federal government, in academia, and in partner organizations. We continue to have our policymaking body of the council with its 59 member jurisdictions. And we are also a capacity building organization that receives both federal and non-federal funding to support STLT health departments to improve their epi and surveillance capacities. I'd like to note that the original function of the council of maintaining that list of nationally notifiable conditions does continue today through our annual position statement process. Since the 80s, CSD has produced over 700 position statements, all of which can be found in our online archive, and I'm happy to throw that link in the chat momentarily. So diving deeper into the position statement process just for a moment or two, position statements are consensus documents that are drafted, vetted, and passed by CSDE members on issues that could result in changes to state or local law, rule, or regulation. There are two types of position statements. The first is policy position statements, and the second is our standardized surveillance case definition position statements. So those set case definitions for what should be reported to public health, and then how public health should classify those reports into cases. Those position statements also set standard actions around national notifiability, including setting the CDC notification timeframes and identifying which cases case classification should be released to the public. The position statement process takes place annually and it's purely member driven. Neither the CSD national office nor our federal partners dictate what position statements our members care about, which ones are developed which year and brought forward to the council. The position statements are developed within our member groups, ideally within our subcommittees or our work groups, and that's just how CSDE is structured as that professional association. And during that development phase and early vetting, CSDE engages all relevant member groups as well as critical partners who should be weighing in on the issues or the case definitions that are being developed. For the hepatitis B position statement, early vetting took place within the viral hepatitis subcommittee that Simone manages, which NASDAQ is also an active participant in. And we ensured that we engaged DBH's leadership as well as their EPI surveillance and laboratory SMEs in the development of these case definitions. Once developed, position statements must be accepted into the annual process by our executive board's program and policy committee, which sets our organization's programmatic and policy-oriented priorities. We then begin our broad formal vetting amongst the full CSDE membership and the council through various online discussion forums, webinars, ad hoc calls, and presentations, etc. The last stage of our process is the approval process, which takes place at each CSDE annual meeting. Our full active membership, so those working at SDLT health departments, may vote to approve position statements to move forward to the council, and then the council has the final vote and say to approve and make position statements official CSDE policy. And that takes place at the annual council's business meeting at the conclusion of each annual conference. So our approval process involves broad CSDE membership and the full council in order to ensure that our position statements are broadly implementable and acceptable, since their adoption could result in changes to SDLT law, rule, or regulation related to reportable conditions, which is a good segue in the end of my presentation, but a good segue into the rest of your call today on the implementation of the Hep B position statement. So I will stop sharing, and I'm happy to take questions at the end or even offline if those come up. Thank you.
Not hearing any questions. So I'm just anticipating then that it's okay for me to jump into my presentation. But also wanted to use a moment. Thank you, Meredith, for covering that whole process. I feel like even I was learning some things there, and I've been through the process a couple times now. But I did want to plug that we are doing a hepatitis D position statement. And our plan for that is not to make it nationally notifiable, but really just to get all jurisdictions on the same page as to how we kind of think about the tests for hepatitis D and how we would classify cases. Again, not nationally notifiable at this point in time, but kind of trying to get that process rolling by actually kind of getting everyone on the same page in how we think about those tests and how we count them. So I'm going to put my email in the chat. And then I will jump to my presentation. So in addition to being the hepatitis unit supervisor at the Minnesota Department of Health, I am also the co-chair for the CSTE viral hepatitis subcommittee. So pretty involved in some of that work. And also was one of the co-authors on the position statement that we are talking about today, which is the hepatitis B acute and chronic position statement. So I'm going to hopefully share my screen here. Walk me through that though. I can never remember where the swap presenter view is in the moment. Going to go through a couple different things about our planning process here. So just a quick overview of some of kind of the topics that I think are important to think about when it comes to planning for this type of implementation is, of course, the first thing you're going to be thinking about is communicable disease reporting, and then implementation, planning, data tracking, and just education about how you get the word out about the changes. So when we think about communicable disease reporting, we need to think about what's already reportable within our jurisdiction. What kind of things do we have in place already that's gotten us some of the way? I don't know if there's any jurisdiction that has everything reportable that they need. Maybe some people do. That's great. I want to really acknowledge along the way here that there is a huge spectrum of where we all are at when it comes to hepatitis B in particular. Not being funded for that work historically. It often comes second to hepatitis C for a number of reasons. So really want to acknowledge that the place that I'm going to share some of our pieces from Minnesota. So really want to acknowledge that the place that Minnesota is in is not, doesn't speak at all to where everyone else is at. But I'm hoping that by sharing a little bit about how we've been conceptualizing it, there may be some things that can help others along the way as well. So thinking about what's already reportable, what needs to be added to your reporting rule to be able to fully set you up for being able to make these types of changes. And some of these things may be things you're already thinking about as we get, more and more focused on hepatitis B. And then, a lot of times we just have to work with what we have because we can't make changes, or it's a little too political at the current moment, or maybe it just went through a round of changes and people are hesitant to open it up again. There's a huge number of reasons that we can run into barriers with this step. The next step is implementation. And these, I want to say I switched around the order of these slides just multiple times because I think the real reality is that this is going to be a mess in a lot of ways, and case status changes always are. If you're just going with 2024 forward, hopefully these steps will be a lot easier. But I want to acknowledge that this is not like a step-by-step guide in any way. It's a lot of circling back to previous steps and thinking through things again and again and again to try to get to a good place. So for a lot of us, we're going to face a decision of, do we update our entire chronic registry, or are we only focusing on 2024 forward? When we think about the chronic case definition, acute obviously is going to be a little bit of an easier world because of course we're only going to think about 2024 forward because that's it's acute disease, makes life a little bit easier. But a place a lot of us will find ourselves in is, what do we do about our chronic registry? And then if we are going to, update in the past, when do we update our older cases? So I kind of broke it down into 2022 and back because our 2022 data is, closed, quote unquote. It's not actively being sent to CDC, but it's in our yearly data and within my state. So we want to make sure that we have that in the place that we want it to be. And then when to update 2023, because we are actively reporting on those. We can't suddenly switch to the new case definition in the middle of the year because that would mess up our reporting to CDC. So we have to figure out when we're going to make that switch, particularly with the current year of data. Because we all know that the data never is closed on, December 31st or whatever corresponding MMWR end of the year date we have. We're still working on that data into the next year. And then we also have to think about, when are we going to update 2024 and forward? When are we going to have that implementation piece of, okay, now we're fully under this new case definition. And so I suggest creating a timeline, and I'll be the first to say my timeline is just all over the place. And so you are not alone if you're kind of turning in circles and feel like you're chasing your own tail with this process, especially if you're in the same realm as we are with updating a chronic registry. So some of the planning pieces that we've been thinking about is, including legal. So any of your legal or legislative folks in relation to updating reporting requirements, what's required to be reported to your agency. Include all the hepatitis staff within MDH. I always view it as lucky because I am possessive of hepatitis, so I get to own them all. Our group does. So our surveillance, prevention, peri-Hep B, we're all in the same place. So it's easy to have a meeting and grab us all into the same room because we're constantly talking with each other. If you are a bit split up where you have areas, folks in different areas throughout your agency, it's a really great idea to have everyone in the same room. Case definitions, this is the first Hep B one in 11 years, I think. But we have Hep C ones that are more recent. We have Hep A ones that are more recent. So there's been a lot of case definition changes over the years. So you may be able to find someone who, if you or your other staff don't have particular experience with this type of change, there may be some resources where they've been through this and they may have some things to share. And that could also be outside of hepatitis as well. If you want to talk to other disease areas and how they kind of conceptualize this. It's a little hard because we're one of the few chronic infectious diseases. So we don't have as many buddies in that world. But you've already got a million things to think about, but why not add one more? So when possible, consider the larger impact or opportunity that you have here as you're adding in some new variables or changing how your variables look. So you can do things like update existing fields or create new ones. And some of this is assuming that you have a surveillance system or some type of tracking system in place. Again, we really run the spectrum of what chronic hepatitis B surveillance looks like within the US. So I just want to keep saying, I know this is not going to be a perfect fit for everyone. But you can also think about how you can streamline data entry or data analysis. And then, adding new reportable serology. So if you're going to be adding a test already, maybe there's another one you could sneak in. Technically, the hepatitis DNA, an undetectable, is not really related to this case definition change. But if you're already doing the work of doing something like making total core reportable, maybe you see if you can also shoehorn undetectable DNAs in there too, if you don't have those already. So, thinking about, is there other things that we can do along the process that have kind of been on our bucket list? And now, because we need to make this step forward, we can also throw a few other things in with it. And so for data tracking, again, assuming some type of surveillance or tracking system here, thinking about what are your current fields, what fields need to be added, what needs to be retired, just really kind of what your data is going to look like in the long run and where you need to go from where you are right now. And I'm going to give examples of Minnesota here too. So if you're like, this is only questions and no answers, I will kind of show things that we have as well. And I see there are some things in the chat, so I will make sure we have time for any questions that there are too. And then, of course, we get to not just do the work of getting our surveillance into a great place, but also making sure everyone else knows about this change. So updating labs on what reporting there might be necessary, including, especially if you have new reporting requirements, so that they're aware of what needs to come. Clinicians, not here, we have not just what testing they need to be doing with new national recommendations they may not be super familiar with, but also of those tests, what do they need to report? And doesn't hurt to be throwing in, how do they interpret those tests? Again, kind of pairing any of that work that you're doing with other work that probably needs to be happening. So when we reach out to clinicians, kind of updating them a little bit, they don't really need to know about our case definitions. It doesn't change their clinical world all that much. But if we're talking about, what they need to be reporting or how they need to report, then we can also just add in messages too about, hey, this is the recommended testing now, and here's what it means based on that. And here are what the vaccine recommendations are based on that testing. Any clarity we can bring to the hepatitis B world at the clinical or provider level is very, very great steps forward, because it is a very confusing disease. And then how can we educate the community too? So testing recommendations, why we want people to be tested, what it means, what to do next. Again, the case definition change doesn't change some of those worlds. But the really great part about our new case definition is that we're going to see more cases in the realm of confirmatory testing, or that's what we anticipate. More of our probable cases will be counted as confirmed cases, but also probable cases will be counted. And so we'll be able to really get, for the first time, a good feel for what the burden of viral hepatitis B looks like across the US. And obviously, we all know national statistics take some time, so it's not going to be immediate because, we need to switch to the new case definition. We need to close out the reporting year and then get those national data reported. So, but it gives us some time to be thinking about how do we get this word out to the community and to our partners so that they know that this is changing and what that means by the time that we're rolling out that data. And then lastly, epi, we are the day-to-day ones who have to deal with the change and understand what it means for our data and how we assign the case definitions. I know anytime we hire someone new, we never train them on hepatitis B to start because they would probably just walk right out the door. So we, lull them into a false sense of security with hepatitis C serology. And then when they're in too deep and they've become these great hepatitis advocates, then we, knock them over with some Hep B testing. So we all acknowledge it's very, very difficult. I think the new case definition brings some clarity, but I think it also brings some complexity. So anything that we can create to, help with how that interpretation works. So like I said, I'm going to share the down and dirty with what happened in Minnesota and where we are at. And again, just want to take a moment to acknowledge we are doing the best that we can do. Some people are going to be where we are. Some people are going to be light years ahead. And some people are going to be sitting here wishing that they could do these things someday. And I certainly hope that we all can someday get to this place and beyond, because again, we're not even close to being fully ready for this. And we're just working through it just like everyone else. So when we think about communicable disease reporting, in Minnesota, we have all diseases reportable within 1 working day. Hepatitis, all primary viral types, including A, B, C, D, and E. So our reporting rule is relatively, Our reporting rule is relatively broad. So it means that in the actual statutes, we don't have it broken down for the most part about what testing is reportable. We do, have some clarity where we say, we do want any test that's indicative of infection. So that gives us a wide range, but then it also says undetectable RNA and DNA. So all test results for the viral load testing. So that is specifically in there to make sure that we don't have any problems when we try to get those undetectable viral loads. And then so what we get to do from there is say, hey, these are the tests that we want. So we want positive results for surface antigen, E antigen, IgM, and then all DNA results. That's the current place we work under. We don't right now request total core antibodies. We don't want E antibodies because that doesn't change our case definition, and it's unfortunately more labs to work with. So it's not really something that we can process. Genotype we do, that's kind of paired in with the DNA results. So we, have a setup where we can kind of let labs know, here are the tests and results that we want reported to us. And then they say, great, they follow that and they get it to us. But when we had to think about what needs to be added, and the answer is total core. And so what we did, let me think about so what we did here is I actually thought we were going to have to go back to our communicable disease reporting rule, make a whole bunch of changes, which would not have been ideal because we were already smack in the middle or right kind of near the beginning of the process of updating that reporting rule and in a place where we would not be adding anything new. And so I was thinking, we have to wait years for this. I reached out to our folks that work with the labs and implementing electronic lab reporting. And I said, okay, we've got to do this. It's going to take forever. And they're like, no, you told the labs not to report this. Now we'll just tell them to report it. And somehow that ended up being super, super easy. So we actually haven't told the labs this quite yet, because by reaching out to our different partners, we were able to come up with a really great plan for that. So when our latest communicable disease reporting rule change is passed and goes into effect, and we are communicating that out to people, we're going to add in the piece about total core and say, hey, here's another change. You need to report this. It's not a change in the actual rule, but it's the perfect time to get that information out in a widespread way through a route that's already well established. So we'll just add on. Another thing we added was reporting of pregnancy for persons with hepatitis C. So kind of adding in that little piece. So that will be, then this will be our other little hepatitis piece, is that now we would like total core antibodies reported. Whereas previously we didn't want to deal with them because it was too much. So now we're going to take all that too much and start getting that. So that ended up being just way, way easier than I possibly expected it to be. So then we have all the rest of the hard stuff. So we decided on a full update of our chronic registry. Sorry, those words are in the wrong order. Full update chronic of registry. That's how my brain feels about all of this. So we decided on a full update of our registry. That's historically what we've always done with case definition changes, is updated our entire registry. So once we kind of pulled that Band-Aid off and made that decision, we had to start thinking about, what does this look like? So this is where we kind of did try to pair it with, what else do we want to do as a unit? What else do we want to think about in the realm of hepatitis? So we did some, I hate these words, but strategic planning to think about kind of the future of hepatitis within our unit. Really recognizing that with the 2103 funding, for example, there's a lot more focus on some programmatic work than there is on just heavy surveillance, which is a lot of what we've done in the past. So other things, leveraging that communication about the reporting rule update, like I mentioned, really easy to just stick that in there, and we don't have to be in charge of this big communication piece. It can just kind of be added in. But some of that strategic planning was around, how can we reduce the workload of our staff? How can we update case report forms so that we aren't asking providers a million questions, where every question we ask makes it less and less likely that they're going to get that form back to us. So how can we make that form that we send out when we have someone newly reported be a little bit less cumbersome? How can we make our fields within the system be a little bit less cumbersome? And how do we, wherever possible, reduce data entry? The reality is we're not funded for hepatitis B chronic surveillance. We do it anyways because we obviously want to, and we have enough support to be able to do that. But hepatitis, especially in the Hep B world, is a lot of finding money under rocks, and sometimes there's nothing there. So we do our best, but we really have to focus on where we can, reducing data entry and focusing on the areas that get us further along in our understanding and prevention of hepatitis B. So I pulled what I view as our very shameful variables from our system. So our current fields, we have IgM, date, and result. And then we have this setup that was like beautiful until this new lovely case definition, where we have test type, and the options are surface antigen, e antigen, or DNA. And then you can put in a date and the result. So this is not going to work well. For people who are really data minded, you can already see the problem in trying to switch to the new case definition. So if, for example, someone had a surface antigen and a DNA on or very close to the same date, it was just arbitrary which one we decided to put in this particular field. So if it's a surface antigen, that means something else under this new case definition than if it was a DNA. If it was a DNA, I would mark them as confirmed right off the bat based on the new case definition. Now, if it's a surface antigen, I have to go in and see whether or not they ever had a DNA. So unlike past changes to our chronic registry, we have to look at the complicated lab data rather than just kind of what we've previously pulled out of the lab data. Essentially, it means a just massive amount of work. So if that is how you're feeling, that is where we are too. So then I kind of had to look at, like, what fields do we need to add? And because of this setup, the answer was we pretty much needed to add all of them. And then what fields needed to be retired? Again, pretty much all of them. So when we think about what fields need to be added, we actually have already added the fields. So we added total core antibody, date, and result. And then for the other ones, we said, where can we reduce data entry? Do we care about the negatives? Because if it's one of these are negative, then it's either that it's kind of not important in the grand scheme of things. Like if a DNA is undetected, but a surface antigen's positive, that DNA doesn't really add anything for us. So what's the point of kind of moving it from one area to another, from our lab area where we kind of have all that messy lab data into the area where we pull our fields for data analysis? So we decided only to track the positives. And I'm really hoping, 10 years down the road, me or whoever the next sorry soul is, isn't in a bad position for the next case definition change. But we decided to only track the positives in here, because then all we have to do is enter a date and nothing else. And so you can see when, and we actually kind of have some nifty coding in here where if the surface antigen is filled out, then a new variable appears of surface antigen 6 months positive date. So like a 6 month down the road. We decided not to go super deep with the coding, but we did try to put a couple kind of fancy things in there. Another example is if the surface antigen and e antigen are both entered, then that 6 month thing doesn't come up, because in the new case definition, if they're both positive, it doesn't matter the distance between them, that person's confirmed. So we tried to kind of simplify it a little bit. So our timeline, and I want to acknowledge this is an accelerated timeline because we are participating in the DVH's case definition evaluation. So if you're not feeling like you're there, it's literally because we have to get them data by mid-December. So we have to speed things up much faster than I normally would. So we're already working on building out the new fields, reports, workflows, etc., all the kind of variables we need to have in order to be successful in doing this change. And then we plan to very, very soon freeze our data from 2022 and back, because once it's frozen, we can analyze that data as a part of when we close our 2023 data. We can have kind of the old version of the data for this last year of analysis before we fully switch over. So we'll freeze all of that, all of the old stuff that's not the current reporting year. And then we'll update all of those to align with the new case definition. And that will be a massive amount of work. And I am still working through exactly how that's going to look. We'll probably have a hierarchy of, we're going to start with the people who are confirmed and just make sure they're still confirmed. Or maybe that will be the last one we tackle, because those should be pretty easy. There shouldn't be too many people who are confirmed that will drop down to probable, but there will be some. So we'll have to have a process of going through and deciding, who do we prioritize? What order do we go in? What work can be done by someone who's maybe a little bit less familiar with Hep B versus needing to come from like one of our few staff who are experts on Hep B. So that is, we've got a month and a half for that. So feeling very optimistic there. And then we're going to close our 2023 data and turn off CDC reporting. And we'll probably do that in early 2024. We need to talk to CDC about that, obviously, of, is that okay? Are you okay that there might be some updates that get missed, but we should have all of our data reported still? But, that's kind of our tentative plan at the moment. And then shortly after, we'll update 2023 data to match the new case definition as well. And so then we've got all of our pre-2024 data in the right place, so that when 2024 data comes around, we can just start right off the bat. That can just be under the new case definition. So that'd be early 2024. So usually we close our data until like April or so, and then we switch over to the new year. So we're going to accelerate that timeline this year and potentially into the future too. And then we'll retire our outdated fields, so that there's not, right now there's, that first set of variables I showed, and then there's also the second set of variables, which, as you can imagine, is just super confusing for anyone doing data entry. So we're going to get to a simplified world in that again. So some education, we will be requesting labs to report the total core antibody. So we already talked about how the process we're going to do that through our existing one with the disease reporting rule updates. We're going to talk about clinicians, what to test, how to respond, or how to report, how to interpret. We have an info sheet that we will be creating for that. Community, same kind of thing. We plan to do that communication through info sheets and provider outreach, community outreach, that type of thing. Pairing hepatitis B in any of the hepatitis C worlds we already exist in, and making sure we're getting it out to as many people as possible. And then I wanted to take a couple minutes to show a tool that I created as part of kind of the viral hepatitis subcommittee work. And I am happy to share this with anyone who is interested in seeing it, but really kind of putting it out there as this is kind of where we can get with some of our epi tools to be able to make case classification a little simpler. And before I jump to that, I'm going to just acknowledge that this tool still will not cover every scenario. It's going to cover kind of the obvious ones. Sorry, not the obvious ones, but the ones that have a clear ending for the most part. Or it's going to end with something like, you probably need more testing, or they need repeat testing, or they need more tests. but hopefully it will cover at least sort of the basics of the case status, especially for people who are newer to either hepatitis B in general or newer to the new case statuses or case definition. But there will always be, you know, weird one-off things where you've got someone who has a positive surface antigen and then 3 weeks later has a negative surface antigen. You know, it's not going to have some of those scenarios where we just need to, you know, kind of have in our brains our understanding of the serology of hepatitis B, and that's probably a false positive. Maybe it's something related to vaccine or something else that could be going on. But I'm going to pull up. So this is a REDCap tool that I created, and hopefully I'm happy to share this link with anyone. I have a nice big note that it's currently in draft status and should not be used for case classification. Also because we're not in 2024 yet, which is when this goes into effect. But it's a tool to kind of try to get at some of the pieces on the clinical and laboratory side of how we define cases. So the first question is, do you even want to assess for acute infection? So if you want to say no to that, you can jump straight to chronic. But let's say yes. And then there is, you know, is there any evidence of seroconversion? Because if so, that's a nice and easy, that's a confirmed acute per individual. If there's no evidence of seroconversion, we're going to the next step. And there's some footnotes in here. I tried to keep them pretty minimal because I didn't want it to be really overwhelming. Like, you know, I think it's like 19 pages case definition document. There's just so many footnotes with Hep B. So I tried to really keep it pretty minimal. This one at the top talks about like, ensure they're not a perinatal case before you're using this tool. And this one, you know, is assuming that there is an absence of a more likely diagnosis. So if we have an IgM and it's negative, that's going to already say it does not meet acute case criteria, because you can't have a negative IgM for an acute case. You can have a positive or not done, not available. So it tries to kind of walk through a positive IgM and a positive surface antigen. That's confirmed. Let's try to go to some of these more sort of random scenarios. Say the surface antigen's not done. Then we have our DNA also not done. We don't have enough. But if our DNA was detected, then we say, do we have acute onset or new detection of one or more of the following? If we say no, again, we're going to meet that, does not meet acute. If we say yes, it's going to be acute confirmed. So it tries to walk through all the different scenarios. And then if we look at chronic disease, we have the HBV DNA. Some of them are really simple, easy endpoints that hopefully will get really familiar to us over time with using this case status. If it's detected, it's chronic confirmed. And if we get to not detected, now we can enter some more data. It's trying to kind of focus on the easiest scenario first. Like if you've got a DNA, great, you're done. You don't, I mean, we want to know about the other tests, definitely, but you don't have to use those in the case definition. It's more just additional data. So if we say the surface antigen was not done, E antigen was positive, total core, we don't have one. Then we get, you know, was there an E antigen 6 months later? And this is where it kind of starts to get into some of those nuanced options. So if we say negative, then it's likely a false positive because all you have is a positive E antigen. If it's positive, you've got a confirmed chronic. If it's not done or not available, you've got a probable. So there are some endpoints like likely false positive or more testing needed, things like that, that really kind of get to you know, some of the gray area there is with hepatitis B, and there's quite a bit of it, but I'm happy to share this tool. It's still in draft form. We still need to get comments back from CDC, but my hope at the very least is that it can be a tool to help determine these case statuses with these new case definitions. Again, it's not going to be a solid fit for every single scenario, but hopefully it will be able to move people through some of these things by focusing on kind of the easiest endpoints first. And then if you're finding yourself a little bit more in some of those weirder areas, hopefully it can help guide through some of that. And then lastly, my plan is for this more testing needed to put in some of the recommended testing options, or, you know, a little bit about some things where, I mean, I'm sure I'm not the only one who has said to a provider on the phone that combination shouldn't be possible. But here we are. So I guess run the test again in a month and just see if everything's the same, you know, trying to provide that guidance in sort of the absence of, you know, being able to actually, give any solid answers. Okay, and then lastly, I'm just going to have this slide up that just has my contact information. If you can't tell already, I'm a huge hepatitis nerd and I love talking hepatitis. It was very enjoyable to make that REDCap database with the case definition logic. I see we have a lot of questions, so I'm going to pass it over to Alan for the moderated piece of our Q&A. But thank you so much.
And Jenny, it's good that there are questions, because if people take one thing away from this, I want them to remember that you are an actual Hep B subject matter expert and I am not. So I'm glad that people came up with some suggestions to put in the chat. There were two that I wanted to raise, which people have partially answered, but which it might not be a bad idea to go back to. One was, and y'all let me know if I have mangled this question. Does Minnesota request or do you receive from providers cases where there is negative Hep B surface antigen, but positive anti-Hep B core and, no, I'm sorry. Negative Hep B, good Lord.
No, you're fine. I see that.
Again. I swear I have read it once. And I will find it again.
I've got it
if you
up
can
here.
see that, it might be good to address that because as you can see that.
So the negative surface antigen with reactive total core or IgM. So we would do two different things, at least in Minnesota, with those results. If we had just a total core by itself, we can't spend the resources to track that down more. We're just going to be under the assumption that either the other testing was negative, and that, if there was a positive, if anything, it would have also been reported. Since we got that total core, we've got evidence that reporting is set up, and that, it's likely just that it's an isolated total core. Maybe they had, like I said, a negative surface antigen, but we're not going to do the work to track it down. When it comes to an IgM, we do that work. So if it's a positive IgM that's by itself, that's where we're going to call and ask to see, ask about if there's any surface antigen on record. Our labs, at least, and maybe others are in a different area, and that would be great to hear, but our labs are in a place where, they can't report one test result contingent on other test results, either at the same date or in the past. So we can't say, we want the negative surface antigens, but only if there's a positive total core or positive IgM. That is just too complicated of a workflow for, really both our providers, but also, just these lab systems in general.
Yeah, unless the provider is giving you like an entire extract of the history and physical, which is nice sometimes when you get that. But yeah, I'm sure that's very hard to configure otherwise.
Yep.
And also asked a couple of questions in the chat, which are easier for me to read at least. Considering practical application of the data, will someone go in and determine if the confirmed cases historically are in care? Is that a resource issue as usual? What are the medical ethics of knowing these data with such a high probability of cancer-related morbidity and mortality?
Yeah, that is a great question. I would say that most of this thought process and work is more around, can we actually get our data in a good place so that we can then support this type of work? So things like moving people along the care cascade, which again is one of the reasons that we're going to update our entire registry. And that is, I just want to acknowledge the comments that I've seen too, is that is not what everyone does. And it may be something they do for Hep C, but they wouldn't do for Hep B or vice versa. But I think that is one of the things that, you can do when you've got a more kind of registry based system, is be able to look and see, different indicators, like when was the last time they had testing? Because if someone hasn't had testing in, whatever marker you want to use, 6 months, a year, 2 years, then it's likely that they're not in care because they aren't getting testing. And, if they're going to be seeing a gastroenterologist, at the very least, they should be having like an E antigen run or a DNA and being able to see some markers of that hepatitis testing. I'm trying to look at that question and see if there was maybe more to add there.
Nope, you got it. Thank you.
Okay. All right, great. Thanks, Anne.
And I know this is something that many of us have experienced. It's definitely a disappointment for us in Arkansas as well. Even for Hep C, people often want to know, what is the number of people who are currently infected? And that's the number that's relevant to somebody who's trying to do linkage to care. And we always have trouble estimating that. And it seems like even people who get negative viral load tests sometimes have trouble as well. Maria, you had a question possibly about the case definition.
Sorry, looking for the mute button. Yes, on page 6 of the case definition, there's a footnote about the middle of the page. It's a 1 cross, and it says, if information on surface antigen test method is available and surface antigen confirmatory neutralization was performed as recommended, surface antigen positive by confirmatory neutralization. My question is, what if it isn't?
Yeah, so do you mean what if it isn't, like what if there was a confirmation run but it wasn't reported? Or what if we have someone who's initial positive but the confirmatory is negative?
No, what if all we have is a positive surface antigen and there is no information on neutralization?
Yeah, so I think that's kind of that place where we make both a leap of faith, but an unfunded leap of faith. So it's the acknowledging that we don't have funding for surveillance. So we're only going to be able to go to, whatever level we can go to within our jurisdiction. So essentially kind of what that piece is talking about is, if you have that information, you should only count it if it is a positive that's been confirmed. If you don't have that information, I can say at least in Minnesota, where we can focus, at least as you can probably tell, pretty decently on hepatitis B surveillance, we do not call and check on every single one. Really kind of, we've seen some, just because of our connection to the perinatal Hep B program, where we've identified like, oh shoot, there are confirmation tests that are happening and we're not getting the negative confirmation tests when they pop up. So then we have to have a conversation with the lab of like, how can we fix this? Because there was a negative confirmation that never got to us. But we didn't really actively track that down. It was sort of found as a process of doing some of that perinatal Hep B work and checking pregnancy status and all those kinds of things. So it is not an expectation or anywhere, I think, within the realm of possibility for many of us to be able to check and call on every surface antigen to see whether or not it confirmed. I think sometimes for some of us, in the lab result, it'll say something like that, or there might be an indication that there's a confirmatory out there, and, keep an eye out if you would expect to get it. Like we get results sometimes that say like sent for confirmation, and we should hypothetically get a second positive confirmation because it sometimes comes in as like a separate test. So I think that's where we just kind of have to be curious and suspicious. And so if you see something that's pointing towards maybe this didn't actually confirm and you have the capacity to follow up on it, I would certainly suggest you do. But it's kind of saying, like it's another one of those areas, if you can do this or if you have capacity, but certainly not a recommendation, because I don't think anyone is in there where they can be chasing down every surface antigen and trying to figure out if it confirmed or not.
So I guess my question is, if I don't have information on neutralization, whether at all, I just get a positive surface antigen, can I take that to be a confirmatory component of my lab evidence, even if it's not confirmed by neutralization?
Yes. I mean, there's some that don't confirm by neutralization. So like they're high enough where they don't need to go to that next level. And I will admit, I am not an expert on how all of that works. I'm not a laboratorian in any way, shape, or form, but I can say in Minnesota, when we get a surface antigen and that is what we have, we assume that to be a true positive surface antigen unless we have evidence otherwise.
Okay, well, then I think that footnote might need to be reworded a little bit, because when I read that, I take that to mean logically that if I don't have that information, then the detection of the surface antigen isn't good enough. That's what I take that to mean. And so I was confused. That's why I asked the question, because to me, when I look at that, it says to me, well, this is good enough, except when this footnote is present, which tells me that it isn't good enough. So anyway, I was just a little confused by that, but you have answered my question. Thank you. I appreciate it.
Yeah, definitely. And I will definitely take a look at that too. I mean, it's in a finalized state, so I don't know if we can make changes at this point, but at the very least, if it does seem like it's a confusing thing and it's not addressed somewhere else where it could provide some clarity in that document, then, it's something that we can keep in our minds for, the next time around, because
Okay.
each time we're just trying to get it a little bit better than it was before. So
Oh, I completely agree. And
Yeah.
and this does make it much clearer to a lot of us, even though it seems like more, it is better. And
Mhm.
your tool on RedCap is awesome. I think we all want to have access to that. Thank you.
Yes, yep, definitely. And I put the link in the chat, and I will certainly share my slides too, and it has the link on there as well. So I welcome any feedback on that tool.
Thank you.
Thanks.
Philip, I did not do a good job reading your first question, but I will try to provide your second also to Jenny, where you noted that you investigate cases that come in with Hep B core antibody only, and you want clarification that the recommendation is just assume that the surface antigen is non-reactive.
Trying to see where that question is.
I can
at, but I see
probably
that.
copy it so that
Yeah, and
have the
Simone, I see
original
put the
words.
footnote in the chat, and thank you, Simone, because I didn't have it in front of me. But
Hello,
um,
can you hear me?
yeah,
Oh, this is Philip. Oh, yeah, you kind of answered my question because
Okay.
I just, like I said, I have lack of faith in our providers because often we don't get the surface antigen because they didn't perform it. So I always have to check. And I guess, like you said, it kind of just depends on the capacity of our surveillance. So I guess I'll keep on doing it because I can. But yeah.
And I would say any places that you can dive in is, certainly not saying take the easy way out. I can just say that we do often take the easy way out because we don't have capacity to go any further with those total
Yeah.
cores.
And it's like you said, it's often that they're only reporting the reactive, so it usually is negative. But every now and then you get that it wasn't reported or it just wasn't ordered because they thought that the core IgM or whatever was confirmatory. So yeah, thank you.
Yeah. And that's a good place too to think about, maybe you can't check on all of them, but maybe you prioritize some populations, like your your persons of childbearing age, in the Hep B program, where it could be a perinatal kind of thing. Or you can identify, places where you can provide some provider education. So if you're seeing a lot of total cores coming from one particular system and that's all you're getting, that may be something where you could do some education too. I think that's why I really like some of the aspects of the 2103 grant, because it really is encouraging some of those pieces around, like, maybe there's certain areas where we can focus some attention on things like, how do we get labs to reflex testing better for hepatitis C, things like that. And I think we can apply that to hepatitis B as well, is where are some of these little areas where we can, make some movement forward.
And that's a good point, because one other thing I'll add is when you see something fishy with the lab results like that, like, a proportion of lab results that does not make sense based on what providers should be or probably are ordering. Often it is a facility level issue where somebody needs to reach out to the facility and do some education. One other possibility that happens sometimes is it is often good to talk with your IT people and ask them, can you explain what is routed to our surveillance system? And sometimes the answer is just, oh, nobody told us that this test was reportable. And, if you tell us, we can turn it on. So that's another thing that sometimes is also helpful to recall. But often it is a provider education thing too. Let's see.
And Alan, sorry, I just want to say, I see a number of people saying more about the neutralization practices. So that might be another, I'm just kind of note that in my brain, Simone, for our next viral hepatitis subcommittee call, and acknowledging that not everyone is on that. But if you are, I think it'd be a great topic for that, because I will admit the number of conversations I've had with facilities around the neutralization practices and procedures, and I feel still like I'm in the dark. And there have been scenarios where we cannot find a solution on how to get those negative neutralizations when they do occur. So that, that footnote can make it a little bit tricky when we know that, like, we have the test method available. And so we know that a neutralization was performed, and then we're kind of in that sort of no man's land of what do we do with that information. So yeah, I think that'd be a great one to bring to one of the subcommittee calls and see who knows anything about this neutralization stuff and how it works, because it certainly confounds me as well.
I want to add, and I'll exercise the moderator's privilege here to say something slightly irrelevant. This is really helpful for me, and I think, like a lot of people, I'm impressed by the red cap tool, which is very useful. But it's also helpful to hear more generally about Minnesota's process for this. I do want to stress, from the perspective of a smaller and lower capacity jurisdiction, Arkansas is going to have to respond to this case definition change by seeing whether we can hire a Hep B nurse. So some of you may be looking at this, like, I'm going to do what Jenny is doing. Some of you may be closer to the place where our jurisdiction is now and trying to see, can we hire somebody to do the adult Hep B because nobody other than the perinatal coordinator is responsible for it right now. That's okay. And I also want to encourage, for anyone who did not get a question answered on this call or who thinks of other questions after this call, please send out emails. Jenny, I'm sorry if that causes your inbox to fill up, but don't send them only to Jenny. Reach out. I'm sure anyone who does surveillance is usually happy to answer these kinds of questions, and I hope people will remember to take advantage of that.
Yes, and myself and my co-authors, Dan Church is the other co-chair of the viral hepatitis subcommittee, and the two of us are more than willing to answer any questions around implementation or what in the world did you mean from this document. I know our CDC colleagues are more than happy to take questions as well. So please feel free to reach out if you have any questions along the way. We know it's going to be a challenge, and we are all in a very similar place as far as taking this big document and thinking about how it works for our jurisdiction.
Is there anything, it has been an hour, is there any last thing that we needed to raise but did not, or any follow-ups? And Simone or Zakia or Jenny, I don't know if there's anything that we ought to add as a last item.
Nothing from me. Just want to reiterate, if you're interested in joining the viral hepatitis subcommittee, please feel free to email me. I can drop them in the chat again.
We're very fun people.
Well, thank y'all, and thanks in particular, Jenny, and also to Meredith for bringing their slides. And Zakia, I don't know if you have a closing remark, but I'll let you go to that if you do.
No, I guess just to thank you all and thank Alan as well for today's VLC session. Seems like there's a lot of things happening with updating the hepatitis B surveillance, and I don't know, I just want to thank you all so much for the great discussion today. I learned a lot. I'm sure everyone else did as well. So thank you. Oh, and we will be back for our last VLC of the calendar year on November 15th, and we'll be talking about the health systems assessment. So we will see you all then. So have a great one.
Thank you all.
Thanks.